Dear distinguished guests, good afternoon. Welcome all of you to join this symposium. The topic today is COVID-19 impact and response in the Asia and Oceania region. This symposium is organized by International Association of Gerontology and Geriatrics, Asia Oceania Region, IAGG-AOR. The organizers are all of the chairs and speakers of this session. They are the President, the immediate past and the past Chairman and the Secretary General of IAGG-AOR. I am Cheng-chieh, the very fresh Chairman of IAGG-AOR. I am currently Vice President of China Medical University, Taiwan. It is my pleasure to moderate this session, and it is our honor to have two discussants with us in the Q&A live session. One is Professor Siriphan SASAT from Thailand. She was the immediate past Secretary General IAGG-AOR, and she is currently Associate Professor, Faculty of Nursing, Chulalongkorn University, and the Vice President of the Thai Society of Gerontology and Geriatric Medicine, Thailand. The other is Professor Cheng-chieh from Australia. He is a physiotherapist and the Director of the Rehabilitation, Aging, and the Independent Living (ARAI) Research Center, Monash University, Australia. And he was the past chairperson IAGG-AOR. Actually, he is the mentor of our organizing team conducting the symposium today. There are four speakers today. The first one is Professor Prasert ASSANTACHAI from Thailand. Dr. Prasert was the immediate past chairman of IAGG-AOR. He is president of Thai Society of Gerontology and Geriatric Medicine and deputy dean of Faculty of Medicine, Siriphan Hospital, Mahidol University, Thailand. The second speaker is Professor Ding-Zheng Zhan from Taiwan. Dr. Zhan is the President Secretary General of IAGG-AOR. He is Director of the Department of Geriatrics and Gerontology and a clinical professor of internal medicine at National Taiwan University Hospital. He is also the co-chair of the Asia Pacific Fragility Fracture Alliance. And the third speaker is Professor Hidenori ARAI from Japan. Professor ARAI is the president of National Center for Geriatrics and Gerontology, NCGG, Japan, the president of the Japan Gerontological Society, the vice president of the Japan Geriatric Society, and the president of Japanese Association on Sarcopenia and Frailty. Additionally, he is the president of Asia Academy of Medicine for Aging and the vice president of Asia Association on Frailty and Sarcopenia. The last one is Professor Julia BYLES from Australia. Professor BYLES is the head of the International Longevity Center, Australia, and the co-chair of ILC Global Alliance. He is the chair of the Social Research and Planning Subcommittee of IAGG-AOR, and she was the past Secretary General of IAGG-AOR. They will give us a comprehensive overview of some key impacts of COVID-19 on older people in Asian countries and how communities and healthcare systems have responded. For example, the positive and negative of vaccinations, the impact of long-term care, the consequences of increasing risk of physical frailty, and ageism, the increasing intergenerational tensions. Best wish for a productive and enjoyable conference. Your participation in this symposium will have a meaningful and lasting impact. Hope you will benefit from it. Thank you and have a good day.
Good afternoon, ladies and gentlemen. The next 10 minutes, I will talk about COVID-19 vaccination for older people. From the data, the infection rate and mortality rate of the COVID-19 infection is quite high in Asia and Oceania, second only to Africa. This is another study show that the COVID-19 death rate is quite high with increasing age from 16 countries. Why old people are vulnerable to epidemics? There are many factors such as biological one, the immunosenescence, the comorbidity, atypical presentation. The other factors such as demographic, behavioral, social, and healthcare. So all these factors can contribute to the vulnerability of old people to epidemics. Comparing to the other two diseases in older people, this is seasonal influenza and invasive pneumococcal disease. You can see the case fatality rate of the COVID-19 is about 2 to 3%. It's lower than seasonal influenza, but higher than influenza, but lower than pneumococcal disease. And these three diseases share the same risk factor for mortality. But when we look into the COVID-19 specifically, we can see the older age has got the highest odds ratio of 6.01, which is the highest one. So prevention is better than cure. At the beginning of the epidemic, our Asia and Oceania ITC, we have launched a mnemonic called COVID ITC Asia and Oceania, such as cat nap to get adequate sleep, to good emotion, exercise, adequate intake, social distancing. So that's the way to prevent to get the disease. But at that time, no vaccine mentioned because the vaccine is just available at the end of the year 2020. So after that, WHO has tried to recommend the vaccine for every people in the world, but because of the shortage of the vaccine at that time, WHO has set a prioritization for target population, such as if any country want to get 10% vaccination in the country, the priority should be placed on healthcare workers and the older people. And if the percentage increase to 20%, you can see again older adult has got the priority as well. But when we look into the real world situation in Hong Kong, you can see the older people tend to get the vaccination much lower dose than those in younger age group. But what about in Australia? The situation is opposite. The older people tend to get the higher percentage of vaccine. Why? What's the reason behind this? Because of the COVID-19 vaccine hesitancy. From the study show that those depend on healthcare provider at that time, at the beginning of the vaccine, the social media, and the internet, a web page, family and friends, as the main source on COVID-19, tend to express higher negative vaccine intent. But the nearly 90% of those healthcare providers who express a negative intent tend to increase from 50% to 90% by the end of this month. Why? Because the more data on the safety of the vaccine. So the WHO has recommended 3 drivers of COVID-19 vaccine uptake. The first one is to create an enabling environment, such as is the location of the vaccine to be given in a close by convenient place. It is about the cost for the vaccine itself, traveling, opportunity, cost of missing work. Time is time consuming to get the vaccine, quality of vaccine of being vaccinated. Do people feel that they are treated with kindness, understanding and respect? And in information, have people been given timely, easy to understand and relevant information? Is it a default in the workplace to vaccinate all employees? And health regulation or mandates such as those who travel abroad. And the second driver is the social influence. At the beginning, from studies show that people in the community are wary of vaccination and believe that vaccine does not work or have a side effects, which will be very bad. They will give a negative signal to others who might otherwise in favor of neutral towards vaccination. Again, predominant narrative in the social media also skew people's perception of what the majority believe and do. So how to harnessing social influence? So we have to make social norm in favor of vaccination more salient, highlight new and emerging norm in favor of vaccination, try to promote the perception that most people are getting vaccinated, and leveraging the work of health personnel, supporting health personnel to promote vaccine. Why? Because health personnel are often the most trusted source of advice on vaccine, and amplifying endorsement from trusted community member. And the third driver is increasing motivation. Be careful that we have to building timely trust in vaccine. If widely rolling out a vaccine followed by announcement of adverse risk can lead to a long-lasting damage in confidence in the vaccine. Leveraging anticipated regret in communication. So we have to convey the message that consequence of inaction and end up in contracting COVID-19 or transmitting to their loved one would be a disaster. And emphasizing the social benefit of vaccination, such as it can create herd immunity if we vaccinate more people. But another issue is people tend to think about the vaccine may be effective, but dose may be too much. Is it true? Is it better to get the less dose of vaccine? It can create the less adverse event. But what about the vaccine effectiveness? So this is another study in Thailand. They recruit the healthy adult to get the intradermal compared with the intramuscular, and it showed that it works. Intradermal can create antibody and less side effects. What about the older people? This is a very big question for us. So we have conduct a study, particularly in Thai older people. For those who get 2 dose primary series of the AstraZeneca vaccine, and to get the 3rd dose of the messenger RNA vaccine. This is our primary objective. So we measure the immunoglobulin and also to measure the neutralizing antibody or NT. At the beginning, we can see the base characteristic of this between 4 arms, which is IDIM of the Moderna vaccine, IDIM of the Pfizer vaccine. So there is no significant difference between these baseline characteristics. Now, come to the immunoglobulin. We can see both the age less than 80 and more than 80 years old. The intramuscular vaccine by the Moderna, there's no significant difference between IDIM. Again, in this older age group, you can see the same, no significant difference. And this is also true for the Pfizer vaccine as well, except for this arm. Now, come to the NT, antibody, which is really robust to attack or to prevent infection. And we can see at the Wuhan variant, you can see those less than 80 years old and more than 80 years old, there is no significant difference between ID and IM regarding the NT antibody. And this is also true for the Omicron as well, between ID and IM. This is by Moderna vaccine. But what about the Pfizer vaccine? This is also true again. There's no significant difference between the NT antibody level between ID and IM in younger age group and older age group. And what about the adverse event? You can see that the intradermal tend to has the lower level of the systemic reaction, but local reaction, the ID tend to have the higher rate of local reaction. Again, the myalgia, fatigue, we can see that intradermal tend to have a lower prevalence of the adverse event compared to the intramuscular. In conclusion, three drivers of the COVID-19 vaccine uptake to create enabling environment, harnessing social influence, increasing motivation. And we can see that the antibody after the third dose of booster, it increased more than 1,000 times after the third booster vaccine. And regarding the immunoglobulin, at 2 to 4 weeks after the third booster vaccine, the Moderna vaccine performed better than Pfizer vaccine in this descending order as follow. Moderna IM is better than Moderna ID, better than Pfizer IM, and better than Pfizer ID. Systemic adverse event after ID injection is lower than intramuscular without significant difference. And the bottom line is intradermal Moderna vaccine would be a good choice for lower systemic adverse event and initiation of vaccine shortage. Thank you so much.
Thanks for having me to the Congress. Today, the presentation for me is the COVID-19 impact and response of the long-term care in the Asia Pacific and the Oceania region. I'm Dr. Derrick Cheng from Taiwan. I'm the director of the Department of Geriatry and Gerontology at the National Taiwan University Hospital. I'm also the clinical professor of the Department of Medicine in the National Taiwan University and also the board member of Taiwan Association of Gerontology and Geriatrics. And the presentation are three parts. The first part is about the COVID-19 infection of the region. And the second part is about the impacts on the long-term care of the region. The third part is about the mitigation strategy in the region. So as we can see here, right now we are in the April. So if you look at the region, roughly around 2021, there's a surge of the infection because of Delta. But right now, when we look at the number, because of the Omicron, the number of infections are increasing. But the problem is that we are very difficult to identify which part of the infection is from the entire population or from the long-term care. So then we are going to look at each country. Let's start from the ABC. The first country is Australia. Then if we look at Australia, the long-term care setting, we can see here the long-term care cases is more than 31,000. And the staff in the long-term care is also then more than the 30,000. If we look at the China cases, they do not officially count the long-term care infections numbers, but they will say that there is increasing workload from lack of protection in the nursing home staff. And also there's a lack of psychological counseling for the long-term care residents. If we look at Hong Kong, we all know that in the recent several months, Hong Kong mortality is very, very high. So then the long-term care mortality are 3 times higher than the usual populations. If you look at India, they also do not have official data on the long-term care infections. But they say that because in India, they do not have very good long-term care facilities. So the long-term care is usually in a community, so probably in a village, and care phones are unregulated. So then the number are usually not trusted. So then they do not have very good result on the long-term care numbers. Then if you look at Indonesia, same is here. They have only limited data on the information on people needing long-term care who are affected by the COVID-19. If you look at the mitigation strategy, which will be reported later, they actually do not have specific guidelines. They do not have specific guidelines. And if you look at Japan, we all know that Japan are very old, and they also have a lot of people living in the long-term care facilities. But then they have a lot of numbers reported that older adults are affected by the COVID-19 numbers. But this number are not stratified by the long-term care facilities. And Japan almost solely rely on the length lockdown of long-term care facilities. But again, we will know that people need to live in their homes or long-term care facilities. So the long-term care lockdown is not a very good strategy. If you look at the South Korea is saying that the long-term care or nursing home deaths is about 40% of the total deaths. So it means that long-term care facility deaths are very important, accounted for a majority of the death. And if you look at New Zealand, if you use it, so they say that the aged residential cares cluster, they account for only 10% of total cases. But it's important here, they accounted for 70% of all the deaths. So which means that when we have a lot of people, they are very old and in a long-term care setting, the mortality rate is very, very high. And also, the healthcare workers in the long-term care is about 50% of the infected residents. So then we also know that the long-term care facility, they accounted for a lot of COVID-19 tolls in these 2021 and 2022 COVID-19 infections. If you look at Singapore, it says that in comparison to other countries, there are only very few cases in the nursing homes. And then all the residents, they were transferred to the acute hospitals, but they do not have separate data about the nursing homes. If you look at Taiwan, before 2022, it's different because in 2021, there's only 120 people in the nursing home got affected by the long-term care, by the COVID-19. But right now, in this couple of days, the daily infection numbers are increasing. Like today is April 28th, and the infection number is above 10,000 people of the country. So then this my Omicron is totally different than the old period. But then in 2021, the entire country kind of locked down. So then because of the lockdown, so a lot of infection control is doing very well. So then in 2021, they actually do not have a lot of infections in Taiwan. So let's look at the mitigation strategies in the long-term care setting. So first part, all the long-term care setting, they need to do the environmental and hand disinfections. So everybody needs to do the hand hygiene. So they will do the alcohol and hand soap. And then in the environment, initially, they can do the preliminary cleansing with the regular detergent. Then later on, they will use disinfectant to make sure the environment is clean. The next part is the airflow. We need to make sure the environment is kind of in a negative pressure. So then the air is kind of drawn out of the long-term care. So you need to do a lot of things to make this happen. The healthcare workers, you need to measure the body temperature and make sure they do wear the mask. And then they also do the infection prevention control training. And then they were arranged to work on the same floor. So they will not cross a different floor to make sure they will not affect other residents in different floors. And then employees